Hello, my name is Phillip Ge from the University of Texas MD Anderson Cancer Center. I'm the iGIE section editor for historical considerations. It's important to understand the past in order to innovate into the future. As a member of the inaugural editorial team at iGIE, I'm excited to launch a section on historical considerations in endoscopy. Over the course of my brief career, I have had the incredible opportunity to have mentors who instilled in me the value of history as a launching pad to innovate and think outside the box. It is my hope that these historical perspectives will provide valuable insights to future generation of endoscopists while encouraging them to further the science and art of gastrointestinal endoscopy via innovation and investigation. In this issue, we will be talking about the history of bariatric endoscopy, celebrating 20 years of bariatric endoscopy and 10 years since the first endoscopic sleeve gastroplasty. 2022 marked the 10th anniversary of endoscopic sleeve gastroplasty, while 2023 will mark the 20th anniversary of the first application of endoscopic suturing to treat obesity, and with it, the birth of the entire field of bariatric endoscopy. Straddling the fields of obesity medicine and bariatric surgery, bariatric endoscopy fills an important niche in our global obesity pandemic. With a strong social media following and growing presence via the ESG and the ABE, bariatric endoscopy is increasingly being adopted worldwide in selected patients with obesity. Christopher Thompson is our inaugural editor-in-chief in an internationally renowned brand, synonymous with creativity and innovation in endoscopy. Dr. Thompson has multiple patents, startup companies, and countless publications to his name, and is credited with having performed the first bariatric endoscopic suturing procedure in 2003, as well as the first ESG in 2012. In addition to having advanced the field of endoscopy, Dr. Thompson has tirelessly mentored numerous trainees, both in endoscopy and in research, receiving the ASGE Distinguished Endoscopic Research Mentoring Award in 2019. It is therefore fitting that a visionary, pioneer, and mentor like himself would be our first guest in the historical considerations section of iGIE. Dr. Thompson, thank you so much for taking the time to do this interview. It's truly an honor and privilege. Why don't you go ahead and tell us a little bit about your own background and training in endoscopy?
Certainly. Well, thanks very much for that, very kind introduction, Phil, and it's great to spend some time with you this evening. So I did my advanced endoscopy fellowship training at the Combined Fellowship, Mass General Brigham. We go back and forth every 3 months, and it was really a great experience. And that's really where I kind of started getting interested in innovation. Before that, I tinkered around a little bit, but I think that's what really started off. And the things that I learned were really very, very formative. So, of course, we learned basic ERCP and EOS skills. However, I was also able to learn endoscopic suturing with Dr. David Carlock. And it was being employed for the treatment of GERD at the time. The device was called the Bariendo cinch. And even in fellowship, I started thinking about, ways to use that to treat obesity. And we started doing some methods, patents, and whatnot. Then when I came on faculty, I was kind of on the lookout for appropriate patients.
So after your training, you then stayed on at Brigham and Women's Hospital. So tell us about your early experience as junior faculty.
Sure. Well, when I came on, you have a lot of heavy hitters in endoscopy in the system there. So I had to find my niche. And the surgeons had a need. They needed more streamlined care of their bariatric patients. So pre-op care, post-op care, complication management. They didn't like kind of having just kind of the random GI docs taking care of that. They wanted one or two people to really be in charge of that and be responsible for it. So being junior faculty, I was happy to oblige. And, I started soon, seeing all of these patients. And that was also a perfect opportunity to look for suturing opportunities. And really, it was gastric fistula that kind of started it off for me. It was, we were already doing anti-reflux procedures, so I was used to using the endocinch device. And then, this fistula, it was a fistula between the gastric pouch and the remnant stomach in a patient with room-wide gastric bypass. And they had bad reflux, and they were regaining all their weight, right? And this fistula was just a couple centimeters below the GE junction where I'm already suturing for reflux, right? So I just needed to convince them to let me kind of go a little bit lower and suture that fistula closed. And so, it's a very complicated surgery, especially at the time. So they were very supportive of me doing this, the surgeons. And surprisingly, the patient did really well, right? The reflux went away and they lost weight. And that doesn't always happen, when you're closing fistula. So, and that kind of started it all off for us. And then, then we started looking for other ways to do it. And the next one was the gastrojejunal anastomosis. That was just a little further south. And we did a lot of background research in that and kind of found an association between the dilated outlet and weight regain. And so we started making the outlets smaller and trying to build evidence so we could do primary therapies.
Very good. And that's such an amazing story, and it really kind of goes back into the very beginnings of the field of bariatric endoscopy. So, naturally,
I actually have the original device here.
Very nice.
This was the original EndoCinch device. And, we turned it into a writing utensil. There's a couple of them left, so kind of fun to have around. But this was a beautiful system to use. It was very streamlined. It connects to the biopsy channel of the scope, and you just kind of go back and forth to place stitches. Then you have to kind of come in and out with the system. But this is kind of what we use, the original EndoCinch. Very nice little streamlined device. And I kind of miss it, but this deserves a lot of credit for our field right now.
What were the limitations of the device?
Well, it was a suction-based suturing device. So the cap was kind of about the size of the tip of a pinky, right? And you had to aspirate tissue into this cap. And then when you activate the handle, right, you push a needle through the tissue and you drop the T-tag off or the needle off on the other side in the distal part of the capsule. Then you have to come out with the device, unscrew the cap, take out the needle, reload, and go back down. So you had to come in and out a lot through an overtube, which was a bit of a, efficiency issue. But also the real problem was the suction-based nature of the device and the size of the capsule was not allowing us to get full thickness suturing. So you're getting good early efficacy signals, but then the long-term weight loss wasn't great.
And I remember you were saying because each individual suture came out of the patient's mouth, you would run into situations where you'd have a lot of sutures coming out of the patient's mouth before you tied everything down.
Yeah, the nurses love that. When you have 17 sutures coming out of someone's mouth and you're clipping them all over we'd wrap the patients in a cocoon and we'd have the sutures coming out and we'd clip them with Kellys to the blanket there and we'd number them. And then they had to do it in inverse order to go back. It's very complicated sometimes.
Right. It leaves very, very little room for error, if you will.
Yeah.
So your initial pioneering work with GG fistulas, that's what really naturally led to the development of outlet reduction. And, how did that step kind of come about? Walk me through the evolution of the procedure and what were the challenges that you needed to overcome?
Well, for the GG fistulas, I think that, first it was just kind of a political one, which, as I mentioned, they did let us do the first one. I'm very grateful it was successful because that gave us some ammunition, if you will, to negotiate and kind of get to do more of those. And I think that was really, if we could not have tried primary first, there was not an appetite for that. Sleeve gastrectomy was just kind of coming out and whatnot, and gastric bypass was, obviously a very effective procedure, and to do primary was very controversial. So we needed stepping stones, and with the fistula, the ability to keep those things closed with this device in particular was not great, right? So that was also a problem because if you get 20 or 30% of these things to stay closed, that was fantastic. So we had to really focus on tissue preparation, ablating or removing the lining of the stomach because mucosa does not want to stick to mucosa, right? The surgeons have an advantage when they're working in the abdomen because serosa, sticks to serosa very well when you kind of approximate the tissue. On the mucosal side, that's not the case. So, we really started learning a lot about tissue preparation. That paid dividends later, of course, with outlet reduction, and ultimately, that was our stepping stone to primary therapies.
Right, and over the years, outlet reduction has gone through multiple iterations based off of what you guys learned about tissue apposition and the quality of tissue and tissue handling, and the biology of tissue handling, if you will.
Yeah, physiology of tissue handling is really important, and now our preferred procedure for outlet reduction is an ESD TOR. So it's a modified endoscopic submucosal dissection where we kind of go all the way around the outlet circumferentially, exposing the submucosa and the muscle, and then we do a perstring around the outlet, right? And we're placing those stitches. They're coming, out through that exposed submucosa and muscle, and you're opposing the tissue and then the tissue just a few millimeters next to it, all the way around. And you size it over a balloon. We go to about 7 millimeters, and it's very durable. The thing you run into is stenoses because it's so good at reducing the size of the anastomosis.
Very good. And the success of outlet reduction seemed to naturally lead to the development of primary weight loss therapies like endoscopic sleeve gastroplasty. Actually, this year marks the 10th anniversary of the first ESG for primary weight loss that you performed with Rob Haas. Tell us a little bit about how ESG came about.
Well, we were kind of working on it simultaneously with the outlet reduction work. So the Cleveland Clinic group, Stacy Breathauer, Phil Schauer, Bipan Chan, they were kind of involved in doing these gastric imbrication procedures surgically. I think they were more commonly performed in South America. And they're inverting the greater curvature and laparoscopically and kind of plicating it. And that seemed like a good surgical analog for us, right? So Roberto Fogel in Venezuela was working on his own form of the procedure where he's really replicating a vertical banded gastroplasty. So that's very different than what ESG ultimately was, in that he was trying to create a sleeve along the lesser curvature, like a VBG. He used one long suture and go down, start proximal, go distal, and then do this kind of anterior posterior thing to create this nice little sleeve, kind of, alternating stitches where you get that nice kind of little sleeve. And I think it worked pretty well early on, but again, it was a suction-based suturing device, so you'd have stitch loss. But conceptually, I wasn't fond of that procedure necessarily because VBGs weren't working surgically. They were going away from them. So I didn't want to make that our surgical analog. And so I worked together with the Cleveland Clinic group to really endoscopically replicate the imbrication procedure where you're taking that greater curvature and folding it in. And we kind of, we embarked on something called the TRIM trial. It commonly was called the TRIM procedure. Too complicated to remember what it stood for, though, right? So that's kind of but it was a gastric plication procedure where patients, would basically, we kind of shorten the stomach lengthwise, and we'd also kind of reduce the width of it, which is the exact same thing we're doing with ESG. And even the suture pattern was very similar. We did several running sutures kind of along the greater curvature. So those were probably the real predecessors to ESG, in my opinion. Got a lot of attention. Have another, show and tell thing was the paper that we had, from the original TRIM procedures. And we made it above the fold here, back in 2008. BC surgery requires no knife. It was very exciting with a big kind of layout inside the new paper as well. Ended up shutting down the phone lines. The hospital really loved me for that. It was a clinical trial. We could only do 8 or 10 patients or something. And we had so many calls from all over the country. It was really surprising, but it showed you the appetite for endoscopic therapies.
And really the appetite for endoscopic bariatric therapy and its place in the management of obesity, right?
Yeah, absolutely.
Very good.
And it was fun working with the surgeons too, because they have a different perspective. You start to really understand, surgical principles. And I think that was a great growth opportunity for me personally, but also for the field.
Fantastic. So is ESG still evolving as a procedure today?
It is. So, we did the first procedures of myself and Rob Haas in Calcutta, India, now a decade ago this year. And we did, a handful of cases there. And we were trying to figure out the most efficient way to do this because we did have the TRIM trial procedure that we were basing it on, trying to reduce that greater curvature, bring it in and shorten it. But it was a different suturing device. And it was full thickness, so we had a shot at getting more durable results. Even though, the TRIM procedure had a good early efficacy signal. It just, you lost the stitches, pretty early. So we were trying to replicate that. And what we ended up doing is settling, by the time we were done with those cases, on what was sort of a double triangle approach, where we would place a stitch kind of distally near the antrum. We place one anterior, then one on the greater curve, then one posterior. We'd back up a little bit, a centimeter or two, and do an anterior greater curve posterior. And then when we would cinch it, it would fold in the greater curvature, but also shorten the stomach a little bit, right? And then we just kind of repeat that. And we had some other little runs of sutures in there as well, because it was hard to kind of do that consistently, or you might have a gap or something you needed to fill. So, but that was the original procedure. And we then kind of tested that out before coming to the United States because this was the second generation of the overstitch, and it was just kind of launching in the U.S. as well. We're using it for outlet reduction. We did do some pediatric cases in 2012 with the device as well at Children's Hospital. But we really focused on kind of building the technique with some other experts. And we did cases in the Dominican Republic and Panama and some other places. And we really tried to kind of build out the series after those initial cases in India.
It's very interesting. And, and actually it's interesting to note that in interviewing you and listening to you, we've come to notice that a common theme to your innovativeness is a very deep understanding of pathophysiology and of mechanisms of action. Tell me a little bit about how that factors into innovations in endoscopy.
Yeah, you're right. It's critical. To really make these procedures effective, we need to think about pathophysiology, but we also have to think about how we can alter normal physiology to get a treatment effect. So we don't just have to wait for a better understanding of pathophysiology. That's great, and it's good to have that understanding and be able to target it directly. But you can also use normal physiology and kind of manipulate that to get a treatment effect. So there's different ways you can go about it, and I think that you have to really be a student of this. For instance, tissue healing was one example. We were able to go from 3% total weight loss with suction-based suturing device, interrupted stitches. We got a full thickness device, went up a little bit to near 6% total weight loss. And then we started doing purse strings with APC ablation. We're up to 8%. And now we're doing ESD with a Torium. We're up to 12% total weight loss. And that's persisting out at 5 years and maybe even longer. I think this next EDW will have 10-year results on 50 patients. So very encouraging when you start kind of using surgical principles and understanding physiology to try to obtain better results. Right. Additionally, when it comes to ESG, we've been doing something very exciting this year, and it's incorporating a myotomy. So if you think, intragastric balloons and ESG, they're thought to work by delaying gastric emptying. That's kind of the general concept, right? So the basic steps of gastric physiology, there's first fundal accommodation, and then there's the mixing and breakdown of food. And then, of course, there's the antral pump that removes the food from the stomach in general terms. And these different bariatric devices kind of all address different, portions or facets of digestion, if you will. So like the original Pose procedure focused on a fundal accommodation. That was the one thing it was doing, really. A bunch of plications in the fundus. And, it was trying to stop that stress from happening to accept the meal and trigger early satiation. That was what it was going for. Ended up getting 5% total weight loss in a randomized trial. It didn't seem like that was the best mechanism. Intragastric balloons and ESG, really, we're putting all the stitches in the body, right? So you're really affecting the grinding, mixing, breakdown of food, and you're maybe affecting a little bit of the fundal accommodation because you're shortening the stomach, right? So with ESG. So some studies have shown that gastroparesis is probably one of the more important mechanisms there. Then we had the transpyloric shuttle. That was very interesting because it really focused on emptying and the antral pump and inhibiting that. So we recently came up with a new procedure we call the GEM procedure, which is gastroplasty and endoscopic myotomy, where we do basically a pylorus sparing antral myotomy. So we leave the pylorus intact. We don't cut that. And we run a myotomy or two, kind of the entire length of the antrum, inhibiting that antral pump. And we've done about 15 or so patients. All the patients that we've done have had significant delay in emptying. If you look at them across the board, the half-life goes from about 90 minutes to over 200 minutes. So now we're getting kind of really more consistent results. So what we're doing is we're adding a new element, right, to this to address the shortcomings of ESG. A myotomy is more consistently, you're able to more consistently perform that. It's just a myotomy of a certain length, and there's so many stitch patterns, right? So you're getting more consistency. Durability is probably there with a double myotomy, right? It's hard for that to grow back. Cost might even be lower ultimately because now we're just doing a myotomy without the suturing, right? That's been the next thing we embarked on, and very exciting kind of early efficacy signals there as well. So I agree, really important to have a good understanding of physiology and kind of have a plan on how you're going to manipulate that to get the treatment results you want.
Exactly, and just like you said, it all boils down to being able to understand the physiology, the pathophysiology of disease, and understanding mechanisms of action and how to take advantage of all of those things to the patient's advantage.
We're well beyond what we used to do, which is just see a surgery and use that as our kind of analog and model after that and try to reproduce it. Endoscopy can do things surgery can't do, and we need to kind of explore that a little bit more.
Absolutely. And you alluded to this a little bit, in the sense that ESG, even in all of its iterations, has remained fairly technically challenging, for which it requires a significant amount of expertise, familiarity with endoscopic suturing. What has been your take on how one develops competency in performing bariatric endoscopy and in ESG, and how do you get your fellows ready for something like this?
That's a big question, and I don't think any of us have the answer to that yet. I think it's important to note that everyone has a different starting point, right? So surgeons understand kind of surgical principles and how to take care of the patients a lot of times pre-op, post-op. And maybe they don't have as much exposure to the device, so maybe they have a technical need. Really strong advanced endoscopists that do many different procedures may be quicker to pick up suturing. They might not be too, but they might be quicker. So they have the technical advantage, but then they have a cognitive deficit where they really need to learn a lot more about taking care of their patients and kind of, patient selection and where they, the different treatment algorithms as well. So everyone's a little different, and that complicates things, right? And then we don't have any good metrics for assessing competency, right? Or for credentialing. So it's a little bit like the Wild West, and that gives the insurance companies pause. So, they want to see that we're doing a good job policing ourselves and making sure that, people are properly trained before they do these procedures. And we're kind of not doing a great job of that right now. So I think that within our fellowship, our fellows do a whole year of this. They do, a couple hundred suturing cases. They come out very skilled, very competent, and, but not everyone can train that way. So we need to think of new ways to help train the practitioners that are already out there. And I think that it's going to take a lot of efforts from the societies as well as our industry partners to do that.
Ryan, part of that is what led to efforts, especially on your end, for all sorts of educational contributions to the field. For example, textbooks, DVDs, hands-on and live endoscopy courses, the Association for Bariatric Endoscopy. All right, these are all, I feel like these are all major contributions that you've made to the education of the field as well.
Yeah, it certainly was a great opportunity. Whenever you combine your research interests with your kind of clinical work, there's just a lot of opportunity to be very productive. And those fellows have been great. We trained over 30 bariatric fellows now, and we consider them bariatric endoscopy and endoscopic surgery fellows, right? Because they do POEM and ESD and other things as well. But those 30 fellows were very productive, and they've published and they've gone on to great, things, and they're very successful. And I think that that's another way to build the field, right? And then they're going to start training people, and then there you have it, right? So that's really the way of the future, I think.
Absolutely. And I think you alluded to this a little bit, but training issues aside, overall, the uptake of bariatric endoscopy procedures still has limitations. What do you think have been the major barriers to adoption here?
Well, I think that there's a technical learning curve, especially with ESG, that is tricky to overcome without volume. Similar to colonic ESD, right? You need a certain number of reps to kind of be comfortable and make sure you're not hurting patients and whatnot. And it's hard to get those. And there's some early studies in that by Reem Sharaya's group and whatnot. And it's a considerable number of patients that you kind of have to scope in a supervised setting. So that definitely slows things down. Additionally, the kind of obscureness of the reimbursement. I think patients certainly will seek the treatment. However, physicians oftentimes get a little pause there because like, if I do this, am I going to get reimbursed for it? Am I going to get paid for it? And so in the hospitals as well, they're kind of concerned about that. So without a clear reimbursement path, that's also causing some people to pump the brakes on it. So that's enough to slow it down. And but it's still making progress and headway. You have several private practice docs now that are coming up with these very profitable centers where they can deliver very high quality care. And then you have more of the academic centers doing this. It just takes time.
And infrastructure too, right? I think this is something where you need the benefit of a multidisciplinary team.
True, that's critical to good results, you know. And when we started out, that was what allowed us to start getting insurance reimbursement over a decade ago, was we adopted the surgical model, right? We knew that for pre-approvals, if I'm just saying this person needs an outlet reduction, we're not going to get it, right? So we made sure we had psychologist clearance, a dietitian clearance. We had a good post-op plan arranged. A lot of times we had the referral letter from the surgeon that we'd include in the packet. And we would really make sure that we dotted all our I's and crossed our T's when we're submitting for pre-approval. And that led to us getting, you know, insurance coverage for a lot of the procedures early on.
Absolutely. So aside from bariatric endoscopy, Chris, you've also been a pioneer in all other areas of endoluminal surgery. You've even started up several companies. How has your expertise and understanding of these other aspects of therapeutic endoscopy influenced your own advancements in bariatric endoscopy?
Yeah, so I think they go hand in hand, right? So with the companies, I was, you know, very fortunate to get several Department of Defense grants when I was just out of fellowship. And it was really focusing on notes, right? So natural orifice transluminal endoscopic surgery, which was, you know, you go through this, come down the mouth, go out the stomach, and try to take the gallbladder out, right? So it was very kind of controversial procedures. But from those procedures came a lot of technologies, right? Anastomotic technologies. We developed magnets that we were originally using for retraction, for retracting the gallbladder so we could take it out. And then we started making anastomoses with those, and they're in numerous clinical trials all over the world right now. And you know, they're going to replace staples for some indications, we think. So that was a great kind of advancement that came out of there, and it is now you know, kind of targeting metabolic surgery, and that's a place where those might be effective. Additionally, we have endoscopic suturing devices. We have many other things, bleeding sensors and whatnot, that were all kind of very I think, you know, very, very much tied to what I'm doing now clinically as well. So I think, again, it's just matching your clinical interests and your volume with research ideas. And then Boston is a great place to do that because you have to do it as a team. You know, you really have to be very fair and you know, find really good people to work with. And that really is how you're successful.
And I mean, there was a lot of cross-pollination as well, right? I believe in your career.
Oh, absolutely. I mean, so with those early grants, I had an ASGE Career Development Award, and this allowed me to cross-train the surgery with Dr. David Ratner over at the Mass General. And that was a phenomenal experience. I learned so much about surgical principles, and really it's just a different way to think. And it took me back to med school, you know, and I really think that we should probably train advanced endoscopy differently. You know, I think doing sort of like what the Brazilians do, a couple of years of general surgery and then get into many years of endoscopy. And I think that would, you know, allow us to have kind of the right mindset for doing these procedures, and you know, also help us to build our skill set so we're technically capable of it. And it's kind of very exciting. So that grant was very helpful to me early in my career.
Very interesting. Where do you see the field going for bariatric endoscopy? I mean, the field has come so far in the last 20 years since, you know, and then about 15 years since that Boston Globe paper even. Where do you think the field is headed?
Well, you know, I'm a big fan of these procedures. You know, we keep getting better weight loss. You know, a lot of our procedures are now hitting 20% total weight loss. And keep in mind, the sleeve gastrectomy gets 25%, in some studies 23%. So we're not far from that. And if we start combining our procedures with medications, we're getting right up there to surgical numbers. So I think, you know, that doesn't mean there's not room. There's no place for surgery. Surgery's, you know, fantastic. It's very, you know, very effective, and we should definitely encourage patients to have surgery. However, the time has passed saying, oh, this is experimental. You know, oh, this might not help patients. We know it helps patients. We have many studies, including the MERIT trial, which, you know, really showed fantastic results. It was a randomized control trial, and it was done during COVID and still got 13% total weight loss, even though patients couldn't go to the gym, and even the control arm didn't get any weight loss because of that, right? So I think that we have very high level evidence for this now. And I think now it's basically training people up to do it, and you know, teaching them how to provide really good care in multidisciplinary centers. I think that's one thing. Making the procedures easier to perform with newer technology, and then kind of being more physiologic, as you mentioned earlier, with our mindset as to how to manipulate these procedures and modify them to get better long-term outcomes. And then also on top of that, we have all these small bowel procedures that are just on the horizon. There's several clinical trials right now with different forms of small bowel procedures, use different mechanisms altogether. Kind of a lot of them are hindgut or maybe work on the duodenum a little. And you can now start to see how combination therapy might be something where we can get more weight loss by using different procedures with different mechanisms.
It's amazing to see how far the field has gone. And, to kind of bring it back to training and mentoring, for a lot of us who have had the benefit of training with you, there's sort of been this common theme of a reverence of how you're able to consistently think outside the box. So I'm going to ask you this. Was this something that you've always been able to do since you were young? Or was this something that was developed, trained, and encouraged?
Well, a little bit. I remember getting in trouble as a child because I was trying to, I was young. I don't know if I was in sixth grade or what it was, but I was trying to take, salt out of water. That was my thing. I was homesick, and my mom had put a vaporizer in the room next to me. And I thought, oh, this could be interesting. So I remember filling the vaporizer up with a bunch of salt and then kind of getting a series of kind of bags and tubes together to try to distill out the salt. And so I destroyed my dresser in the process. It has a nice big white stripe over the front. So I was always kind of interested in that and taking apart clocks and things. I don't know. But that went, and I, always working on my cars, right? So, but it kind of went quiet. Throughout med school, all of a sudden, you're more interested in guidelines and kind of memorizing certain facts, and that creativity starts to die out. And then when I was in my advanced fellowship, Dr. Bill Barugi at the General really reawoke that, and he started assigning me projects that, I thought I would need to be an engineer to work on, right? One of them was looking at biopsy needles, for the pancreas. Rather than FNA. And so that was one of the early projects I was working on, trying to figure out why the existing ones didn't work and how to create a new one. And then another system to drain pseudocysts more effectively. And so I started, really digging into that, working with engineers, coming up with ideas. I couldn't CAD, but I learned how to start, using some software to capture some of this. And it was amazing. It was a very valuable part of advanced endoscopy fellowship for me. And that's what kind of reawoken that kind of, innovative spirit.
I think it's very inspirational, and especially in this day and age, there's been a lot of recent focus, I think, amongst a lot of our professional societies about professional satisfaction and burnout and that sort of thing. So I think, in medicine, this professional satisfaction is critically important to keeping us grounded, keeping us motivated, and really preventing this phenomenon of burnout. So what drives you to contribute every day?
Well, I think that being clinically active is important because you see patients that have needs, and every week you see a patient where they have a need. And, a lot of times it's, well, there's no surgical option. IR can't do something to help them. And then you need to think creatively to help that patient. Now you could easily say, well, I'm sorry, we can't help you. But that's kind of not what the burden's been about, at least, and my mentors always would try to go the extra mile to figure out a way to help them. And I think that's what drives a lot of it. And then once you kind of figure out a way to do it, then you got to figure out a way to make it easy. And you have fellows, you figure out a way to make it easy enough the fellow can do it. And then, ultimately you start talking to companies about devices that might be able to make the procedure a little more streamlined and effective. So I think it all comes down to the patients, right? And patient need. And, with obesity, it's a pandemic, right? So, and at the time, there were a lot of patients I was seeing with complications from the old VBG procedures and some of the other ones that were still kind of around. And you just saw all the problems with those older surgeries, and made you want to innovate something to help the patients.
Absolutely. And speaking of fellows, how do you view mentorship and your ongoing relationship with all your mentees?
Yeah, well, we love the fellows. They, every year you get, a new batch, and they're so, so enthusiastic, and they want to contribute to the field. And that kind of youthful enthusiasm is something that is very necessary in academia, right? And we love teaching them skills, and it does help the procedures become more refined, right? Because I've done a few thousand suturing procedures, right? But teaching a fellow who's never touched the scope to do them is a different story. So it really encourages us to modify the procedures to make them, kind of a little easier to perform. It teaches us kind of new ways of training them too. So we have a simulator that we use, and I remember before this is to train outlet reduction, so you can do an outlet reduction. And before we before we had the simulator, it would take fellows over 50 cases, 45, 50 cases, something like that, before they could actually do a whole procedure on their own. And now we have them practice in the simulator, and we give them a test. And after they pass the test, which can take several weeks, right? But when they pass the test, usually their very first case, they don't need any assistance. So that's a very effective simulator, right? And everyone on their second case is able to do it. So, and you shorten the learning curve. It's a little more pain up front, right? But you shorten that learning curve, and we need more people to be investigating this, right? Different ways of training, shortening the learning curves, adjusting the procedures, and I think that we're going to get there. I think that, it's kind of just starting to build a head of steam. So it's a very exciting time to get involved in bariatric endoscopy.
Absolutely, and I've seen your recent bariatric endoscopy family tree. You're at over 30 fellows at this point, having completed the Brigham and Women's Bariatric Endoscopy and Foregut Endoscopic Surgery Fellowship. I'm sure it's been a very, very fulfilling experience, and I think it's interesting to think about not just the mentorship that occurs during the fellowship, but also the amount of support that you give to your mentees afterwards as well, as they are taking on different roles as junior faculty, in terms of supporting them as far as ideas, mentorship, or even just how to overcome adversity, how to overcome complications, and how to continue that sort of pioneering spirit and rise up, if you will. Tell me a little bit about that.
Well, I had very good mentorship, and I think that was critical to my success. I remember early on in my career, I was a few months on faculty, and I'm doing these fistula closures, and we had a very bad complication. Person ends up having had von Willebrand's disease. We didn't know about that at the time, and he didn't report it. He didn't know it, and he had bled a lot during his original procedure, but that was not even at our facility. So we're trying to close a gastric fistula in this gastric bypass patient. We're pulling a flap of tissue over. We have multiple stitches coming out the mouth, like I described earlier. I'm trying to pull this flap of tissue over, and we just avulse a large portion of the mucosa in the pouch, kind of near the staple line. And there's several blood vessels in there, and the thing just starts bleeding like crazy. Now, the guy had a small outlet to begin with, right? And so there was really no place for the blood to go but out the overtube. So he was spraying blood out this overtube, and it just kept coming and coming and coming. And there was no stopping this. I couldn't see anything in that little pouch. Couldn't stop the bleeding. And we're just flooding blood into the guy. He had mesh in his abdomen. So the surgeons who knew we were doing the procedure, and this is why they wanted us to, they said, we can't get in there to stop this. There's mesh, and it's going to be crazy hard. He was also too big for the IR table. So IR said, we can't really help you. So, it was very traumatic for me. And then fortunately, my mentor, Dr. David Carlisle, came in, asked if he could help. And I said, yeah, please. And he solved the problem. He stopped the bleeding. It was not easy, but I'm glad he was really patient and stuck with it. It was a very hard procedure. He ended up snaring off all the tissue and, putting a bunch of epinephrine down, but he was successful. And after that, I remember meeting in his office, and I came in and said, we were only a handful of cases, I don't remember, but I said, okay, I guess we're done with this experiment, right? Because that was just so traumatic, and you don't want to hurt people, right? And his advice was so important, to the development of the field and to my career. He basically said, it's your decision, obviously, but it's a turning point for you, right? If you want to innovate and you want to continue to build these procedures, you've got to get back on the horse. You've got to get back in there, and you've got to continue doing this, right? And he was going to support me in doing that, which was key. Or, you can just give up on it and, become just a very good therapeutic endoscopist, but you're not going to be building this field like you want to. So his support was critical. And I think you need good mentorship. You don't want to just go out and be kind of the only doc doing these procedures if you want to innovate. Now, if you're just going out and, you're going to, do a good service, you probably can do that. But if you want to innovate and you want to develop new procedures, you need mentors. And I try to be the same kind of mentor that he was to me.
Absolutely, and you've been every bit of it a phenomenal mentor to all the rest of us as well in the field, both in bariatric endoscopy as well as the broader field of advanced therapeutic endoscopy. So closing things out in a couple of short points, what advice do you have for mentees and those of us who are interested in innovation and investigation in GI endoscopy?
Well, I think that it's really important to understand, as we talked about, the basics. And you have to also, master the basics, the fundamentals of endoscopy as well. Because if you're not good at those, you're not going to be good at anything else, right? So we harp on the fellows about tip control and all sorts of little nuances that, doing everything with your left hand, don't do a lot with your right hand, et cetera. There's so many little teaching points that you start early. You start with first-year fellows, and every fellow needs to really focus on the basics and the fundamentals. They need to make sure they get that down. You can't cut corners, you can't skip that. So that's the first thing, because you can't get good at the real advanced work unless you're good at the basic work, right? So I think that's the first thing everyone can work on and everyone can do. Then the next thing is understanding physiology, like we talked about as well, right? You need to kind of really have a firm grasp of physiology. If there is information on pathophysiology, you want to understand that too. So whatever area you're working in, you want to really kind of master that also. And then, you need to have the right mentors, right? You need to have people that will allow you to push the envelope and be there to kind of be your safety net, and help you to pioneer and push things forward in a way where you're comfortable doing it. And I think those are kind of things that if you do those things, you'll increase your chance of being successful in innovating.
Very good. Dr. Thompson, it's always a pleasure, and thank you so much for this interview. It's absolutely a pleasure to hear all the reflections that you've had on bariatric endoscopy. It's really such a huge honor to be able to interview the guy who's responsible for a whole field, and to have been mentored and trained by you. And again, thank you so very much for taking the time out of your busy day to provide this interview.
Well, my pleasure. And, there's a lot of people involved in building this field, and not just the former fellows, but there's a lot of different people. There's surgeons, there's medical doctors, there's a whole group of people that are working so hard to push this forward every day. And I'm really looking forward to reading your piece, because I want to see that timeline you're working on that goes through all the milestones of bariatric endoscopy and the people who did the first poses and the first endominas, and all that's going to be so exciting, because it's really important to learn from others as well, right? And I was wonderful, right place, right time situation for me, and I was able to contribute. But there's so many people contributing and continuing to contribute, and I'm looking forward to reading your article.
Absolutely, we'll look forward to seeing it together. It'll come out in the December issue of iGIE, issue number 1. Congratulations.
Thanks very much.